Postdoctoral Fellow for the CAPE Project, which stands for the Community Assessment and Education to Promote Behavioral Health Planning and Evaluation. CAPE is a partnership between the Substance Abuse and Mental Health Services Administration and the United States Department of Agriculture's National Institute of Food and Agriculture, along with the Regional Rural Development Centers. You can find more information about the CAPE project at www.healthbench.info. I'm pleased to introduce to you today Nancy Roget, who is the Director of the National Frontier and Rural Addiction Technology Transfer Center Network, or ATTC. Nancy will be presenting a webinar today about telehealth technologies with her presentation entitled Technology-Assisted Care Interventions, Enhancing Treatment and Recovery Support Services. And we're very excited for this webinar, and Nancy, thank you for being here with us today. If you have questions as Nancy is presenting, please type them into that chat box over on the left. And it's all yours.
Thank you. Okay, thanks. Hopefully I can forward the slides as well. Thank you for this opportunity. I really appreciate the chance to talk with everyone today. And if you have questions, just type them in the box, and I will stop as we go along, or I'll take questions at the end as well. So let's see here. So we are the National Frontier and Rural Addiction Technology Transfer Center, and we're one of 15 centers funded by SAMHSA. And let me go over the purpose of the ATTCs is to develop and strengthen the workforce that provides addictions treatment and recovery support services to those in need. So our primary client is not actual folks who are receiving prevention, treatment, or recovery services, but the folks that provide those services. And we work in partnership with single state authorities. Those are the folks that manage the SAPT block grant funds in each state, treatment provider associations, addiction counselors, lots of different professionals, including MSWs, marriage and family therapists, psychologists, and then most importantly, faith and recovery community leaders and family members of those in recovery and other stakeholders. Here's a map of the regional ATTCs. There are 10 regional ATTCs that are funded, and they are aligned with HHS regions. Also, there are 4 national focus areas, and you can see the National Frontier and Rural ATTC, that's us, and we're located, our office is located in Reno, Nevada. We have the National American Indian and Alaska Native ATTC, which is located at the University of Iowa. We have the National Hispanic and Latino ATTC, which is located in Puerto Rico, and then the National Expert ATTC, which is located in Pittsburgh, Pennsylvania. And all of these national ATTCs work throughout the United States, the Pacific jurisdictions, and the Puerto Rico and the Virgin Islands to provide training and technical assistance activities for folks that are interested in these particular topical areas. So this is what I'm going to be talking about today is introduction to the ATTCs. I just did that. Going to go over recovery definitions, which probably all of you are well aware, but I want to make sure we're all talking about the same thing. And then I'm going to discuss the use of technology, different digital types, technology-based interventions, and then I'm going to talk about 4 specific studies on technology-based interventions that are being used in recovery, and then I'm going to talk about recovery apps. So let's look at the definition of recovery. This is a CASAT SAMHSA definition, and thought leaders in the field have defined recovery as a voluntarily maintained lifestyle characterized by sobriety, personal health, and citizenship. Another definition by Alexandria Laudet. She is one of the leading researchers in recovery. She said those who experience it themselves have described recovery as a new life or a second chance. And just to remind folks what we know about recovery and about relapse is that relapse is particularly problematic in the first 3 years of abstinence, and that future lifetime relapse rate drops below 15% between the years of between the 4th and 5th years of recovery. And this is a well-known writer on recovery, and if you want a lot of resources regarding recovery, you can visit his website, which is up here. It's www.williamwhitepapers.com, and he's a very strong advocate for recovery, and as you can see by his statement that recovery by any means necessary under any circumstances, and that there's no wrong door to recovery. We don't care how somebody gets into recovery. More importantly is that they are in recovery and that they establish a support system that supports their sobriety, their citizenship, and their life in the community. Great quote by William White as well: recovery is contagious. Get close to it, stay close to it, catch it, and keep catching it, and pass it on. So when we start looking at recovery and treatment, and we start looking at rural and frontier issues, what are some of the barriers that are involved? And some of the things we need to look at in helping folks get into treatment, helping folks set up recovery support services, some of the barriers are privacy and confidentiality, travel costs and burden, time away from work, childcare. For example, let's take an intensive outpatient program. Many intensive outpatient programs require clients to be on site at the treatment agency or at the treatment provider approximately, let's say, 3 to 10 hours a week. So if for folks that live in rural, in remote areas, it may be a 2-hour or 2-hour drive to get to the treatment center. And so when you start thinking about all that time and the cost and the gas, even though gas prices are going down right now, there's a huge burden on the client as far as how are they going to get to treatment, and can they work and go to treatment? What do they do with their kids? And when we start looking at privacy and confidentiality issues, certainly we start looking at how can we provide services remotely that remain private and confidential. When we looked at a study by Elliott and Larson in 2004 regarding adolescents in mid-sized and rural communities, these researchers found that barriers to receiving care for these adolescents included a lack of healthcare information, a lack of healthcare access, poor insurance coverage, certainly parenting issues, and confidentiality concerns. And we know confidentiality concerns are very well, they come to the surface pretty easy in rural and remote areas and in small towns, because we know that sort of everybody knows everybody and kind of everybody knows each other's business. And some other data points are that specifically there are few substance abuse treatment programs in rural areas, certainly where there's unfortunately where the need is substantial. And also another study that was done demonstrated that rural probationers may have to travel long distances to receive services and to be in compliance with the terms of their probation. This was another study done more recently, and she found that rural probationers were less likely to be involved in peer recovery support programs or self-help groups like AA or NA, and that was due to being in remote areas where there was a lack of access to services. So also we know with rural youth, and these were in all three different rural categories meaning different size of rural and remote areas. But what we're finding is that the rural areas people used to perceive as, oh, they don't have as many drug or alcohol problems, But that is really not true. Recently, we're looking at rural youth having higher rates of alcohol, cocaine, and methamphetamine and inhalants use, and in fact, higher rates than urban youth. And methamphetamine and alcohol use are higher in rural areas than urban areas. And the more rural the area, the higher the use. Okay. So, if we take those issues into consideration, let's look at technology. Okay. So, what would you say if you could easily expand your treatment services, provide supportive services to your patients 24/7, expand the reach of your treatment services, provide patients with additional personalized feedback, clinically fill some of the hours for your intensive outpatient clients, help patients increase their knowledge about their chronic conditions regarding substance use disorders, connect your patients with other patients with similar conditions outside of the treatment provider, ensure that patients had the time to really learn about relapse and relapse prevention strategies. What would you say? Well, this little guy has the answer, and what we're going to be talking about is technology-based interventions, which have been shown to do most of those things that I just talked about. Okay, so let's talk about technology in general. Technology has certainly invaded our lives, and now our profession. Okay. Well, I'm going to go over some data points with you here. This comes from the Pew report, and they're really the experts as far as having sort of the latest data regarding use of technology and the internet. So 87% of Americans use the internet. 90% of American adults have cell phones, and 58% have smartphones. And then no matter a person's salary, more people own cell phones than use the internet. Really important data point to keep in mind. And Americans now spend an average 34 hours per month using mobile apps and mobile web browsers, but only 27 hours a month getting online with their PCs. And I'm sure you're starting to see that shift as well. People using tablets and their smartphones to access the internet rather than using laptops or desktop computers. 29%, speaking of that, 29% of Americans own a tablet, and the average American owns at least 4 technology devices. So a smartphone, a tablet, a laptop, a desktop, all those type of things. And then when we start looking at text messages, 80% of Americans send and receive text messages. And we have this new category of perpetual texters. So adolescents ages 13 to 17, they average sending and receiving that number's right, 3,339 texts a month. So it's about 6 texts per waking hour. And young adults ages 18 to 24, sending about half of that, sending and receiving 1,630, or about 3 texts per waking hour. Okay. And people always ask us, well, what about clients? This was a study done in 8 urban drug treatment centers in Baltimore with 266 patients. I haven't seen any studies done with clients substance use disorder treatment clients who live in rural or remote areas as far as their access. But what we do know is that clients in these urban areas had access to mobile phone, about 91%, text messaging almost 80%, but you can see really access to the internet, email, and computers was much lower, almost half. And so what we know is that clients do have access to telephones, or to mobile phones, and to text messaging. Another study that was done found that 95% of teens receiving treatment at emergency room had access to mobile phones and participated in text messaging. And what this study was looking at was text messaging based behavioral interventions were shown to be really acceptable in this study, valid and reliable with teens on a variety of sensitive topics. All right, and this is just one study that just recently came out from Reno and colleagues, and she's doing her work at Brown University. So let's look at digital types. And why we're going to discuss digital types is that this is something that certainly impacts our field. So we know that technology started to invade our lives. It's starting to invade our profession. It's starting to come into the treatment and recovery services that many providers are starting to offer, and we have some folks who might be more resistant to technology-based interventions or using technology, and the question is why. So let's talk about digital types. Digital types is a term that was coined, if you can imagine, way back in 2001 by Prensky, and he came up with the term digital immigrants versus digital natives. So let me talk a moment about digital immigrants. Digital immigrants, and let me point out, yes, that is for you that are not digital immigrants, yes, that's a typewriter. It's not the typewriter I used in graduate school, but it's pretty close. And then the other is a rotary phone on the left. So digital immigrants are people born before or around 1964, and those are folks who grew up in a pre-computer world. Zur, who has a great website, and if you just Google Zur, you can get to his website. He also talks, he and his daughter also discuss digital types. Okay, so I'm sort of this is not a self-portrait, but I am a digital immigrant. I hope I'm sort of not disclosing my exact age, but I certainly grew up in a pre-computer world, and it is not my first language. So when we talk about digital immigrant, we're really talking about what is your mode of operating. And while I'm pretty good with computers and my cell phone and all of that, I still get myself stuck, and it's not my first language. Okay, and like all immigrants, as digital immigrants, I have to learn to adapt to my environment, and in some cases, I always keep my accent, my digital accent. And what do I mean by my digital accent? I'll give you a quick example. My son, who is certainly a digital native, he was home from graduate school. We were talking about him going to the store, and I said, yeah, thanks for going to the store for me. If you can pick up a few things, let me get a piece of paper and write down a list. And he said, Mom, I have my phone. And I said, well, that's good, because then if I forget something, I can call you and tell you, or text you and tell you what I need. He goes, no, I don't need paper. I've got a notes section on my phone. I'll just type it in while you talk. And that gives you an example. I didn't think of, oh, yeah, you can just type in the note. We don't need any paper or pencil. And so one of the issues that we're talking about here, and for me, I'm also Norwegian. My grandfather came over from Norway when he was 17, and so I am a digital immigrant, and I do have this digital accent, and sometimes it sort of interferes with my ability to think that we can provide different services by using technology. Now, what's the other side of the coin is digital natives. These are native speakers of the digital language, of computers, cell phones, video games, and the internet. Okay, and Zur says that digital natives have digital DNA flowing through their bodies. And we can look at a comparison. So digital immigrants prefer to talk in person or over the phone, where natives prefer to chat, text, or message through social media. A lot of digital immigrants, not all, but some, don't text or only do so sparingly. And digital natives text more than call. Immigrants tend to prefer synchronous communication, where digital natives may prefer to text or to talk asynchronous. Okay, you can see natives may want to receive information slowly in a linear fashion, logically, where natives are used to receiving information quickly, a lot of different information at the same time, multitasking. Natives prefer reading text like books, and where digital natives may prefer processing. Now, there's lots of different ways of splitting digital immigrants versus digital natives. It's not only based on age. We know we have some let's say 65-year-olds that we would say would probably, even though age-wise they would fall into the immigrant category, they're really digital natives. So you can sort people according to attitudes, comprehension, relationships, practices, excuse me, and comfort with technology. And there's Feeney and Toledo also have articles that move away from the digital natives and digital immigrant terms and use different terms to discuss the differences. So, why is this important? Well, if you look at it, recent data, 70% of individuals who received substance use disorder services were under the age of 40. While the problem is while most of the folks providing the treatment services are well over the age of 50 from different workforce studies. So what we have is we have this digital divide where we have counselors and therapists over 50 who tend to be more digital immigrants versus clients and patients who are digital natives. And so what we have happening a lot of times, we see in treatment right now, we'll have clients and patients wanting to text their counselors, email their counselors, and having this technology, they're used to using it, where we have counselors who may not be as familiar, or their providers have not resolved some of the HIPAA privacy and security issues regarding providing technology-assisted care. So let's talk about technology-assisted care. Here's a definition from Kathy Carroll and her folks at Yale. Excuse me for a second. So here's the definition. Use of technology devices to deliver some aspect of psychotherapy or behavioral treatment directly to patients via interaction with a web-based program. Okay. So I'm going to go over some of the characteristics. Technology-based interventions are flexible. They provide automated and tailored information. Some programs are automated and tailored, and some are just automated. To date, there's more than 100 different programs using technology-based interventions, and they've been developed for a wide range of mental disorders and behavioral health problems, as well as physical disorders. Technology-assisted care or technology-based interventions, I'm using those two terms interchangeably. They can consist of text, audio, video, animations, or other forms of multimedia. They use information from medical records, physiological data capture devices, or other sources, and may be interactively customized or tailored to an individual's user needs. So, technology-based interventions can be on computers, they can be on tablets, most of them are web-based right now, they can be on smartphones or on telephones. And yes, telephones are still being used to provide continuing care. We see lots of studies on telephone monitoring and relapse prevention and continuing care. These are just examples of studies. Specifically, we're going to be looking at interactive voice response, which is using the telephone. I'll describe that in a little bit. We also see web-based screeners like the Drinker's Checkup, where these are open to the public and anyone can go in and do a quick screen and get feedback regarding their level of alcohol consumption and get some tailored advice. We also know there are web-based support groups out there. We'll talk a little bit about those. There's also virtual reality programs. There are several treatment programs that we're aware of that are using virtual reality, especially with their adolescent clients. Okay. We also know there's some research out there, in particular with returning vets with substance use disorders, and they're using video games. This is there's one created called Guardian Angel, and that seems to be having an impact on reducing the number of drinking days for these vets. Now let me talk about some of the technology-based intervention characteristics. Okay, most of them are fairly cost-effective. They certainly transcend geographical boundaries. They facilitate linkages to services in one's community. And I think this is probably one of the biggest selling points, is that clinicians have the opportunity to extend their reach by offering additional services outside of the normal clinic hours. And settings that use technology-based interventions, we're seeing emergency rooms are using interactive voice response or web-based expert to, and hopefully most of you are aware that most Trauma 1 emergency departments are required to do screening and brief intervention referral to treatment for their patients that come into the trauma center. And many of these trauma centers, like I said, are now using interactive voice response or web-based screening and brief intervention with tablets. I'll talk about that in a minute. We're also seeing technology-based interventions being used in prison settings, specifically TESS, which is therapeutic education systems, that have been shown to be effective and used in 10 prisons in 4 states. And then MAPIT is a web-based intervention that's created by Walters, and they have used that in Texas. And then we're seeing some initial studies done in public schools where a web-based screening and brief intervention program was initiated with middle school students, and this is still in the pilot phase, but they found some initial good results. Also, many universities are using a web-based screening program for those students who are arrested on a minor in possession charge or have been found to have some sort of alcohol problem. Now, what are the functions of technology-based interventions? Well, they really could serve as a foot in the door. And what do we mean by this? Well, we have a lot of clients that are hesitant about going into treatment for a variety of reasons. And if if an individual is able to sort of test out treatment by participating in a technology-based intervention, they might find that treatment wasn't so scary, they had good access to it. Okay. Also, technology-based interventions can help providers implement evidence-based practices. Okay. Let me give you an example here. Many technology-based interventions use the following evidence-based practices: cognitive behavioral therapy, community reinforcement approach. You can just read down those various evidence-based practices. And this, by using technology-based interventions, treatment providers could point to the particular technology-based intervention they're using and say, yes, this is one example of the evidence-based practices that we are providing. They also, think about this, extend the reach of the clinician. Now, when we're thinking, let's use therapeutic education systems as an example. Many times, so a therapeutic education system has 65 modules that they use. They're all about different areas of drug prevention, recovery. So let's say instead of spending time with each of your clients talking about drug refusal skills, what if your client was able to come to the treatment program, log in, get on a computer and go through a series of educational scenarios where they learned about drug refusal skills, and that was part of their treatment. And then when they were done with that, they could go and talk with their counselor about what they just learned, while the counselor or the therapist is maybe perhaps spending time with a client who's going through a crisis situation. So we're really talking about using technology to extend the reach of the clinician. Okay. Also, technology-based interventions can be offered as standalone interventions, and this might be particularly relevant for those that live in rural or settings where access to care is pretty limited. So really what we're trying to do is how to do this, bring somebody into a supportive environment, into a group setting, into a recovery support environment, or do counseling, okay, and be empathic and help people talk about their issues using technologies. So let me talk about 4 studies here. So research has demonstrated that text messaging can produce effective behavior change results across diverse youth populations using pretty short behavioral-based interventions. And you can see the citation, different studies on this. And the research studies also that have been shown efficacy using texting have been around clients with issues regarding weight and obesity, clients with diabetes, clients with asthma, clients that are tobacco dependent, and issues regarding sexual health. And there's good studies regarding that using text messaging is helpful in treating these conditions and providing support. So, for example, a text messaging behavioral intervention designed for smoking cessation among youth demonstrated improved quit rates at 6 weeks. This is just an example of one study. So let's talk about the specific study of text messaging regarding a pilot study with adolescents to promote recovery support. So this is with a study done, I believe it's Rachel Gonzalez out of UCLA. She had 80 adolescents and young adults ages 12 to 24. They had completed an outpatient residential program, 12 to 6 weeks. They came from 6 different treatment providers in LA County. They were all asked to use their own phones, so it was a program that was that they accessed through their own phones. It was a 12-week program, and SMS messages were sent from HIPAA-compliant data center servers, okay, to these adolescent clients. And this is post-treatment, so this was all about promoting recovery and promoting support once folks had completed an outpatient or a residential treatment program. And so all the clients participating got a monitoring text message, meaning they got a message like, how you doing today? And the text also requested that the client send back a feedback text like, having a rough day, these are the number of cravings I've had. There was a wellness daily recovery tip text that was sent, and also there was a weekend text that had some substance abuse education material in it. Okay? And the wellness recovery tips that got sent out at least once a week were address issues regarding personal health, social health, emotional health, physical health, and the content for these tips were derived from the CDC's Getting Healthy and the Kaiser wellness programs. And this just gives you an example regarding how the text messages might appear. This example is not from this particular study. This study didn't give an example. This comes from Karen Ingersoll's work, and she's running a similar type of text messaging study. So you can see the text is, how's your mood right now? And you can see the code, and then the person replies mood hashtag, and you can see the client replies mood 4, extremely positive, and then the text back, have a nice day, and then another text that, did you take your medication today? Text back, meds yes or meds no, meds yes, and then the text back, keep up the good work. Okay, so this just gives you an example of perhaps what the client would see. And then a recent study examined the outcomes of a web-based multimedia recovery support intervention offered as a continuing care following residential treatment. Now we're moving into a web-based recovery support program that was done out of Hazleton, and the intervention included tailored clinical content delivered as a multimedia format, as well as access to a recovery coach. Once again, this was most of it was post-treatment, and initially, the utilization of this web-based program was pretty high, and then utilization decreased over time. And this is pretty typical of what they find in other disease management programs, like for heart disease, diabetes, but there was a significant, in this particular study, there was a significant association between the number of modules that a patient or client accessed and abstinence rates 1 year post-treatment. Controlling for motivation, self-efficacy, and pre-treatment substance abuse. Okay. And I know I have 2 questions, and let me get to this, and I apologize for not getting to them sooner, but I will get to your questions. So this, once again, we're talking about this web-based recovery support program where clients post-treatment could go in and go through a series of different modules, all revolving around recovery support, and then also they had access to recovery coaches if they were having more significant types of problems or issues. The next one I want to talk about is interactive voice response. And when you think about this, think about it, I always call it sort of telephone hell. But you know, when you get on to check your bank balance and you have to press 1 for this and 2 to listen to this, and sometimes it can be frustrating. Well, what researchers have done is they've actually taken, hopefully, the frustrating pieces out of this and have created interactive voice response, which allows patients or clients to go in and to listen to different modules, and especially when they're having problems or need support. So let me give you the definition here. Interactive voice response is an automated computer-based interventions, and they've really shown promise in treating substance use disorders as well as other chronic diseases. They're fully automated. And they're very low cost. It's a really consistent delivery. There's access, there's greater access and availability of treatment, and there's increased flexibility of scheduling and convenience. We see interactive voice response also being used in emergency rooms and in primary care offices to provide screening and brief intervention. This particular study was done. They had patients use interactive voice response to go in and listen to different modules. Patient used the system on almost 10 out of the 28 days. They found the system interesting, helpful, easy to use. They rated most of the modules very positively. The calls were generally brief, like 10 minutes, but most patients access the majority of the content domains. Let me give you, this is a sort of an infographic or a description of what the recovery line for methadone, what they included. There was a secure login, an introduction for first-time callers, and then they had 3 daily questions. There was different learning opportunities. There were daily assessments and questions. Patient services where someone could request different services so they could call and transfer to the clinic. There was a list of weekly groups, and you can see on the other side there were speeches and talks excuse me, and different kinds of modules that folks could listen to. Once again, this is called the recovery line for methadone using interactive voice response. The last one I'm going to talk about is the use of smartphones in recovery support. This is a pretty big study that was done through the University of Wisconsin, Dave Gustafson and his group on HS, and basically they took Android phones and downloaded these applications for clients in drug and alcohol treatment programs. There were monitoring and alerts. There was reminders. There was a GPS system put in. So the researchers bought the phones, gave the phones to the clients, and the clients were allowed to use these phones. There were some really interesting things that they did as far as they had clients upload pictures of people that were important to them, maybe why they decided to stop using drugs and alcohol, so that when they felt like using again, they could look at the pictures of why they were doing this and the importance. One of the neat things they did is they had a GPS system, and they put in they had clients, they talked with clients, and they put in the clients' high-risk areas and where they have used drugs in the past or used alcohol in the past. And so what would happen is when they would get close to these high-risk areas, their phone would go off. And using the GPS system in the phone, and it would send them a message like, you're getting close to one of your high-risk areas. Do you need to log in and call a sponsor, call your counselor? These were used as adjunct to treatment services, so they were used while folks were in treatment. And they got some really good results by using this smart phone program. Now, the last thing I want to I have two more things I want to talk about, and that's when you think about psychoeducational services. So many drug and alcohol treatment programs use psychoeducational services, and sometimes they're provided in group sessions, sometimes they're provided in individual sessions, or they're part of homework assignments. And I don't know if you remember the old days, but I certainly do. We had patient workbooks where we would teach people about the disease of addiction and how to set up a recovery program, and lots of different psychoeducational related topics. So what we're seeing now is many of these technology-based interventions are sort of a technology replacement for these workbooks, and many of them now include so this therapeutic education system, which is created by Lisa Marsh and her group out of Dartmouth, they take this interactive web-based psychosocial intervention, and it's grounded in community reinforcement approach, CBT, and contingency management. And it also has 65 different modules that clients can listen to. You can see some of the topics are listed here: substance use and abuse, so drug refusing skills, coping with thoughts about using, risk reduction for HIV, AIDS, and STIs, cognitive and emotional regulation, so how do I manage negative thinking, and then psychosocial functioning regarding effective problem solving. Right. So this gives you an example of what this particular TES modules, what's available and what clients can have access to. This is one of my favorite comics or cartoons, and boy, I'd sure like that on my phone that says, "Are you sure you need that muffin?" Well, we have some smartphone apps as well, and I want to talk about those because a lot of counselors seem to be saying, oh, just go to Apple or just go to the Android store or the Google store and download some apps on recovery support. And I think we have to be careful about those, and I want to make some points on that. So 71% of Apple's alcohol-related apps were aimed at facilitating drinking games or liquor store locations, not at facilitating recovery or recovery support. Now, there's about 1 million apps in the Google Play Store, and 87 of those apps in the Google Play Store that focus on addiction recovery. 1/3 of those were free, and 9 of the apps were the most downloaded apps and accounted for about close to 85% of all the downloads. None of these apps have been formally evaluated or studied, and we're not sure where the provision of information comes from, but they're focused on providing some information about the condition of having a drug or alcohol problem and to enhance motivation. So let's talk about apps that provide information. It seems to be very popular to provide information on addiction and recovery. It includes information on literature not related to 12-step. And then it also includes 12-step literature such as Big Book, description of the 12 steps, and description of the 12 traditions. And then there are also of these 9 apps, some enhance motivation, so aims to enhance and sustain motivation for sustained recovery. Some contains prayers or meditations. Some include recovery stories, so speaker, audio text, personal recovery stories, AA and NA stories, and then enables user to create a list of things to do or when they're feeling like they're in a high-risk situation. Recovery apps that enhance motivation also include sometimes inspirational quotes, gratitude lists that you can put together as far as things that that the client is grateful for, exercise videos, or photo storage like we talked about with HS. Some of them also facilitate social support and connectedness, so there might be a meeting or service locator tool to help folks find mutual aid, support group meetings, or online communities that allow people to connect with folks that are involved with online support. And then social support and connectedness, quick access to connectedness, and then apps that provide feedback, show progress. You can put in how many drinks that you've had. It can chart that over a period of time, and inspirational message like, great, you didn't drink today, congratulations. And features that folks liked about these apps: portability, user-friendly, easy to use, free, having lots of different functions, and you could use them in meetings, and they're pretty discreet. Also, there's available podcasts and radio shows that clients can access if they have access to the internet. So I want to end and say recovery is contagious. There are many pathways to recovery, and that we hope professionals will view technology as a powerful partner and so that it improves quality and productivity of behavioral health care. So whether it's group counseling like this or like that, or client homework in this old workbook, or like this using interactive voice response, what we're looking at is technology-based interventions or technology-assisted care in the client's best interest, because it expands access and it enhances treatment services. So we hope you'll catch the technology wave with us. We have more learning opportunities on our Telehealth Tuesdays. Our latest one is not tomorrow because it's Veterans Day, but it will be this Thursday. It'll be a webinar. You can come to our website and register for it. We'll be talking with Chris Four from Indian Health Services to talk about Native Americans' receptivity to the use of video conferencing to provide mental health related and substance use related treatment services. So I'll be happy to take any questions that you have. I see in the chat box. Okay, Scott said, I know digital natives are less concerned about privacy, but do users worry about having their information about substance abuse or other problems pirated or otherwise used against them? Yes, and unfortunately, I think some patients are not as concerned as they need to be, and so I think it is up to us professionals to be concerned for them and to help provide structure for how to access counselors and therapists using HIPAA-compliant devices. Let's see. I would think this would be a big concern, especially to those who are employed or over the age of, say, 35 to 45. Yes, sometimes we see that split regarding age. And can you get a copy? Yes, the webinar is being recorded. I'd like to take any other questions folks have. I know we're at 11 o'clock, and I apologize for the delay in starting.
Well, Nancy, thank you so much. What a wonderful presentation. I have a couple of questions for you. Are there certain technology-based interventions, whether apps or texting programs or whatever it may be, that are very popular? Perhaps is there a most popular intervention right now?
You know, I think when the last couple of slides I went through, and you can see what apps are being used by the general public for recovery support. You can see people are very interested in apps that provide motivation and give them access to other folks. What we're seeing, though, from the research literature is that we know that web-based screeners are being used more and more to do screening, that people like the privacy. And that really a lot of folks seem to be more disclosive when they're going through, when they're using a web-based screener rather than talking to a healthcare professional, that they may actually admit more use or more high-risk behavior that they might be more embarrassed about to tell a professional. So we're seeing some real interest in different settings about using these web-based screeners. Also, the literature really supports the therapeutic education systems tests that we talked about with the 65 modules, and then Kathy Carroll's work in CBT for CBT, which is 6 modules, and I think Kathy Carroll and the TES work, or CBT for CBT and TES, can both be purchased, and you can contact the researcher. So those two are accessible right now.
Great. So if a community or a practitioner wanted to use certain technology-based intervention, what's the best way for them to get started with that? Is there an organization that might provide training or content, for example, for some of the text messaging programs that you talked about? Or I guess I'll leave it at what's the best way for someone to get started?
Well, they can certainly contact us. That's part of our job. And so our contact information, I think, is up there. If not, I can send it to you. And our website is www.nfar. Oh, it's right, right there on the last slide. So you can certainly contact us, and you can ask for Nancy or Tara or Wendy, and we can talk about the training that we have available, and we can also point you in the right direction. There is a lot of information out there, and we see a lot of folks who are quick to jump and buy certain equipment, and then come to find out that it's not HIPAA compliant, and then they've spent all this money, and boy, that gets frustrating.
Oh, I can imagine. I would just like to point out to all of the participants that we do have a survey evaluation. If you could fill that out, that would be fantastic. It is located in both the chat box. Rosa typed a note about it, and then in the notes underneath the presentation slide, the link to the survey is there as well. So if you could fill that out, that would be fantastic. I don't see any more questions. So Nancy, I would like to thank you again for your time today. This was a fantastic presentation. Very good.
Thank you.
And we really appreciate it.
Sure. We appreciate the opportunity. Thanks, everybody.